You know, we talk all the time about how important it is to get oxygen in. But what happens when the real danger isn't that at all? What if it's about not being able to get carbon dioxide out? Well, today we're diving into a really critical condition called hypercapnic respiratory failure, which is exactly that, a dangerous buildup of this waste gas.
All right, so here's our game plan. First, we're going to break down what hypercapnia actually is. Then, we'll get into the emergency signs you need to look out for and how doctors figure it out. From there, we'll explore the amazing ladder of modern treatments, and we'll wrap it all up with the absolute key messages you need to remember.
So let's start with the basics. What are we really talking about with this forgotten gas? And what's going on when our body just can't clear it out?
It seems like such a simple question, right? But it gets to the absolute core of this issue. We are just so focused on needing oxygen. But trust me, the inability to get rid of CO2 is every bit as life-threatening. It's a failure of ventilation. And that's what we're focused on today.
Okay, to really get this, think of your lungs as having two main jobs. Job one is oxygenation, getting oxygen in. Job two is ventilation, getting CO2 out. Hypercapnic failure is when job two completely breaks down. And in the medical world, there's a very clear line in the sand. When the pressure of CO2 in your arterial blood, the PCO2, climbs above 50 millimeters of mercury, that's it. That's the official diagnosis.
So, if your CO2 levels are climbing into the danger zone, how does your body let you know? What are the warning bells it's ringing to tell you something's wrong?
Now this is fascinating and a super important clue. Shortness of breath, or dyspnea, can happen with both low oxygen and high CO2. So that alone doesn't tell you the whole story. But when a patient shows up with shortness of breath plus a headache, that combination is a huge sign pointing right at hypercapnia. It's a massive red flag for any clinician.
And it doesn't stop with the headache. High CO2 actually makes your blood vessels widen, which leads to this telltale redness in the skin and even in the whites of your eyes. Your heart starts racing, trying to compensate. And as that CO2 level gets even higher, it starts messing with your brain, causing confusion or even a really specific kind of hand tremor called asteraxis. It looks like their hands are flapping.
All right, so you've got these signs. The suspicion is high. How do doctors go from "I think this is what's happening" to "I know this is what's happening"? This is that moment of truth in the diagnostic process.
And this is just a critical point to understand. As obvious as some of those signs might seem, they can also be really subtle, or they can look like a bunch of other conditions. So a doctor's suspicion is the starting point, for sure, but it is not enough. You have to confirm it with cold, hard data.
And that leads us to this clear, two-step pathway. It all starts with that high index of suspicion, piecing together the patient's story and what the physical exam shows. But the final word, the test that seals the deal, is the arterial blood gas analysis, or ABG for short.
This machine, right here, is the gold standard. A tiny sample of blood is drawn from an artery, and this analyzer gives the doctors the precise numbers, the exact levels of oxygen, carbon dioxide, and the blood's pH. This is what changes suspicion to a confirmed diagnosis and tells them exactly how bad the situation is.
So once that diagnosis is confirmed, it is a race against time. And the modern approach to treatment is just brilliant. It's like a ladder of support. You start with the least invasive options first and only climb higher if you absolutely have to. Now, this strategy is twofold. You're fighting a battle on two fronts. First, you have to go after the root cause. Is it a COPD flare, pneumonia, what is it? But at the exact same time, you have to provide immediate backup to fix the dangerous gas exchange problem that's happening right now.
And here is that ladder. You can see how it escalates. Doctors start on the lowest rung possible, maybe with just high-flow oxygen through the nose. If that's not enough, they climb to a non-invasive mask. If that fails, they move to an invasive breathing tube. And in the absolute most severe cases, the top of the ladder is ECMO, a machine that literally does the lungs' job for them.
Let's just focus for a second on the huge difference between rungs 2 and 3. On the left, you see non-invasive ventilation, or NIV. It uses a really tight-fitting mask to push air in and help blow off that extra CO2. On the right, that's invasive ventilation. That requires intubation, putting a breathing tube right down the windpipe. The goal is always to win the battle with the mask, because intubation comes with more risks.
So how do you pick the right tool for the job? Well, high-flow nasal oxygen is fantastic for boosting oxygen levels. But non-invasive ventilation, that is a total game changer for things like a bad COPD flare-up, where the big problem is high CO2 making the blood acidic.
It can literally prevent the need for a breathing tube. And then there's ECMO, the ultimate safety net, a last-ditch, life-saving option for when the lungs have failed, but there's still a chance they can recover.
All right, we have covered a lot of ground here. So let's just boil it all down. What are the absolute critical messages you should take away from all this?
Okay, first and foremost, remember this is a ventilation problem. It's about getting CO2 out. Second, that combo of shortness of breath and a headache is a massive red flag. Third, you can't just guess. You need that arterial blood gas test for a real diagnosis. And finally, remember the ladder of support. We have these incredible non-invasive tools now that can prevent more aggressive treatments. It's all about escalating only when necessary.
And that leaves us with a really fascinating question for the future, right? Our tools, especially the non-invasive ones, are getting so much better. We're able to help patients who just years ago would have gone straight to a breathing tube. So does that mean we need to start changing the very definition of respiratory failure? Could we catch it and intervene even earlier? It's a huge question that doctors are actively thinking about right now.